Naluwooza Winnie. I've just finished my MEd training, and I did a research in pediatric intensive care in Mulago. Just so before we begin, it's aligning quite well with our theme today about improving access to anesthesia and critical care in Uganda. Just a brief question. Does any of us know how many pediatric ICUs we have in the country? We have specialized pediatric ICUs. Then we have a general pediatric ICU. So I think we have one in Kua and also Kosu. They run pediatric ICUs, but they are specific for those populations. Then general pediatric ICUs in private and government, we currently have one at Mulago. And that's a big problem because we all know pediatric population requires special care compared to adults. Admitting these children in adult ICUs creates a lot of morbidity and mortality for the children. So my study looked at the only pediatric ICU we have in the country, the general one, and it was established about 1.5 years ago in Mulago. We are going to look at the findings, and they are quite interesting. So this was the title of my presentation. I looked at the clinical characteristics and factors associated with 14-day mortality of patients admitted to the PICU at Mulago National Referral Hospital. These are my supervisors who I was privileged to work under, that is Dr. Mary T, Mary J, and Associate Professor Luggya Tonny. Operation definitions. In my context, clinical characteristics are looking at provider diagnosis at admission, comorbidities, mental status, source of admission, and vital signs. While respiratory support and other supports are specifically looking at any form of support given to a particular system. Organ dysfunction is just looking at the clinical or laboratory confirmed derangement of an organ to work to do its physiological function. So looking at the background of this study, globally, acute pediatric illnesses are the leading cause of death in the pediatric population beyond the neonatal period. We have a very high mortality in pediatric population, ranging from as high as 6 to 7 million worldwide. Sadly, over 70% of this mortality is occurring in the low and middle income countries, and Uganda is among those. And can I say sadder, more sad of this, is that we don't have pediatric ICUs in these low and middle income countries. And even those countries that have tried to establish, that is Ethiopia, South Africa, a bit of Nigeria, they have great variation in the mortality reported in these PICUs, ranging from as high as 1.3 to as high as 50%, meaning for every 2 children admitted to a PICU, one of them will die, assured to die. It is associated with factors like long distances, different variations in the disease patterns, among others. Uganda is not differing from that trend. Why this study? As explained from my background, we have the recent establishment of the only general PICU in the country, and we've not studied the factors, the disease patterns, the interventions, and the mortality in this unit. So we set out to find those and as well provide guidance to protocols and allocation of the resources, which are quite very limited in our setting. Specifically, we set out to describe clinical characteristics, determine the 14-day mortality, and secondarily, to identify factors associated with this mortality. This was a prospective cohort study. It was quite a descriptive study. It was a baseline stroke pilot study in the unit and in the country. It was done at Mulago, that is in Uganda. We had 100 patients enrolled for the study consecutively. Study period was 6 months, and follow-up was done for 14 days. That is on day 1, day 7, and day 14. Analysis was done using descriptive statistics, modified Poisson regression to identify the associated factors. We included all patients consecutively, as already explained, and excluded those that are non-consenting and also those who are readmitted to the unit. The study profile, we assessed 105 patients for eligibility. 5 were excluded because of non-consenting, while the others were readmissions. We admitted 100 patients, and of the 100 that were admitted, 74% of these patients died, while 26 survived by the end of the 14 days. Of the 26 that survived, only 12% were transferred out of the unit by the end of the 14 days, while the 14 still remained in the unit. This is indicating that for every 4 patients admitted to the unit, 3 of them are sure to die, which is quite alarming for our population and generation as a whole. The median age was found to be 36 months. That is, most of the children were aged below 5 years. 94% of the patients came from a distance greater than 5 kilometers from the unit, which is, we know distance is associated with increase in mortality and morbidity. 47% of the patients had comorbidities, and of these, 51% of them had malignancy as a comorbidity. This is important because most of the patients that had malignancy came in quite very sick and at the age of death, and this population contributed to a lot of the mortality that we had in the unit. Mulago has pediatric oncology, which is near the unit. 87% of patients had multi-organ dysfunction at admission, while severe pneumonia and septic shock were noted to be the predominant diagnosis at admission. The median stay in the unit was 23.3 hours. This is quite very low. This is meaning that most of the patients admitted to the unit were exited, died within 24 hours of their stay, compared to the 14 days of follow-up that we did. And alarmingly, of the 100 patients we admitted, 51 of them had died within the first 24 hours. But even further, of those that died within the first 24 hours, their median stay was 1.5 hours in the unit. I hope you see where I'm going with the mortality. Most of it is occurring within the first 2 hours of admission to the unit. As mentioned earlier, our mortality is alarmingly high at 74%. This is a Kaplan-Meier curve. It is showing the survival probability. And as we look at the results, survival mortality probability is greatly reducing within the first few hours of admission to the unit. The secondary objective was looking at the associated factors. So this study got a bit of challenges while doing the secondary objective because we had a small sample size. This gives you a bit of wide confidence intervals. But despite that challenge, we still found factors that were very, very significant in this study. There are about 3. Cardiovascular support was found to be associated with increase in mortality by as high as 38%. This is not to say that cardiovascular support led to mortality, but is to show that patients who received this support had severe illness and as such were more likely to die. Mechanical ventilation was found to be surprisingly protective in our study. It was protective by a factor of 25%. This in this study could be explained by the fact that we lack intermediate support means, that is like high flow nasal cannula and non-invasive mechanical ventilation. So patients that could benefit from those supports are instead straight away given a mechanical ventilation, and thus giving us the protective factor from this mechanical ventilation. Cardiac arrest was found to increase mortality by as high as 45%. This agrees with most studies worldwide where patients that experience cardiac arrest have severe derangement in their physiology and as such have reduced chances of survival. In conclusion, this study found that most patients were aged under 5 years. Majority had multi-organ dysfunction at presentation. Severe pneumonia and septic shock were the commonest diagnosis at admission. and mortality was found to be very high at 74%. The factors associated found significant in our study were cardiac arrest, cardiovascular support that were indicators of severe illness. Mechanical ventilation were associated with lower mortality because of potentially timely and effective respiratory support given to reversible pathology like severe pneumonia. We recommend increase in PICU bed capacity and establishment of more PICUs in the country to reduce the distances traveled, financial burdens, among others that would help improve our mortality and also reduce morbidity. We recommend targeted management of high-risk groups, that is the cardiac arrest patients, like establishment of protocols that would give you better outcomes. We recommend further research into factors associated with mortality, especially within the first 24 hours, and also getting the PICU registered in the ICU registry. This would give us more data over a longer period of time to analyze more factors associated with mortality and morbidity in this unit. Thank you for listening, and special thanks to my supervisors, the PICU staff at Mulago, by statistician, and also the families that participated in this study.